Well, thank you. So I guess Dr. Venki gave me all the tough things that I don't really typically do. And this is percutaneous direct carotid access. So direct carotid access is not uncommon. Has been used, commonly used techniques for the other adjunct for other procedures. TAVR is a good alternative access used for TCAR routinely. That's a direct carotid access. Aortic arch repair, routinely we use carotid as a part of the, either to do a TBE or put another branch or device in there. Now, I'm not quite sure about percutaneous carotid access. Now, let's just look at use carotid as alternative access. And so this study was done 2018, look at the feasibility of using direct carotid access for TAVR procedure. Looks good, but it's open carotid exposure. And now has been used fairly routinely for patients with poor femoral access. This is a study was published last year, look at TCAR procedure, and then again, it's direct carotid access. Neck bleeding is not uncommon. Neck hematoma happens in about 7% of patients, 2 of which require either readmission or reintervention, but 7% of patients has some sort of a bleeding neck hematoma complication. Now, this is more relevant to this talk. And this is 46 patients underwent endovascular arch repair. And this is a multi-center study, retrospective review. They actually access carotid directly through percutaneous puncture, use a 7 French sheet to deliver additional branch during carotid aortic arch repair. 1 dissection, 1 open conversion. Look at other complication. 1 patient received cover stent for not be able to close. And 1 patient received a delayed surgical conversion for pseudoaneurysm, and 4 patients need prolonged manual compression. I'm not quite sure what that means. I just want to remind you, when we talk about prolonged manual compression in the femoral access, there's bony problem that we can compress against femoral head. In the carotid, the most relevant bony landmark is trachea. So you really have to compress the trachea to achieve really good compression if there's really bleeding. Now, as we get more comfortable with carotid access, direct carotid access, there's a new technology developing using percutaneous carotid access. This is an abstract that was published, but I haven't seen the full paper yet. And basically, it's 8 French sheets access to carotid directly. Now, it looks feasible, but then we don't really know the outcome. So what can go wrong with percutaneous carotid access? Well, bleeding, well, you can have trouble compress because the really close to the bony landmark is your trachea. What else? Big hematoma. This is obviously, you can see it's not carotid, but we see in a percutaneous access. It's not uncommon with larger sheets, patient on continued anticoagulation or do antiplatelet therapy. Larger hematoma that here in the common femoral, you can go in there, try to evacuate hematoma. In the carotid, it can be a big problem, compress the trachea. Exercise infection, pseudoaneurysm or infected hematoma, that would be disaster for the neck. And closure complication, we all see this as a surgeon that you have brain posterior plaque against the wall, now you close the entire common femoral artery. Can you imagine if that happens in the common carotid artery and causes some thrombus within the carotid? And it's not exactly ideal outcome you are looking for. And hopefully you never have seen this. You are never going to be able to see this. This is a closure device, can be stuck in the artery and for a variety of reasons. So overall, with this said, I say it could be a disaster. And have not done a percutaneous carotid access, at least not intentionally. But I think we need to be cautious about percutaneous carotid access.